It's time to focus on seniors with Helping Seniors TV. The television show designed to make you aware of senior issues and needs, as well as to acquaint you with the resources available to help you age in place and with dignity. Now, here's your host, Joe Steckler.
I'm Joe Steckler, and welcome to Helping Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plans. Our topic today is heart care, and joining me is Dr. Jason Foreman, clinical cardiac electrophysiologist. I got it.
Very good.
Welcome, doctor.
Thank you, Joe. Thank you for having me.
You're quite welcome. Folks, Dr. Foreman, he's a homegrown guy. Grew up in Satellite Beach, went to school, got his medical license and everything else, became a doctor, and came back here and been back here 1 month.
Absolutely.
How did you pick Wuesthoff?
Wuesthoff is growing as a corporation, and they have a lot of opportunity, and it just seemed to be the right fit for me.
Yeah. Are you the guy that's going to be what is a clinical cardiac electrophysiologist do?
As a clinical cardiac electrophysiologist, we treat abnormal heart rhythms. Whether the rhythm is too slow, the rhythm is too fast, it's an abnormal heart rhythm that we can treat in a variety of ways, whether with medications or through procedures.
Let's talk about that, guys. For years, I used to get a feeling of my heart thumping. And one day it thumped, and I had a lady in charge of one of our programs. She called 911, and they came to the office, and they bundled me up, put me on the gurney, and took me in the wagon on the way to Wuesthoff, and that heart thumped again. And I watched the expression on the paramedic's face, and his eyes got kind of wide. And I said, "What happened?" And he said, "Your heartbeat's 30. That's pretty low."
Absolutely. Absolutely.
So they put me in Wuesthoff. Dr. Messerschmidt said, "You're not leaving this hospital until we put a pacemaker in."
Right.
And that started me on the route to a lot of care at Wuesthoff over the years.
Yeah, I bet so. Yeah.
But I have to compliment the staff and the doctors at Wuesthoff, because I have had exceptional care at Wuesthoff Hospital, and I've never felt that my best interests were not served by the way I was treated at Wuesthoff.
Absolutely. It's a great organization. I'm proud to be part of it now.
So one of the things that it's been coming to my attention over the years, Dr. Foreman, is that the type of work you're doing with slow heartbeat and fast heartbeat, you mentioned pacemaker, you mentioned medicines, but there are a lot of actual slicing. You're grinning, but you're doing things to the heart muscle itself instead of using medicines. Can you elaborate on it? Help our viewing audience understand what you're doing today and how the care of the heart is changing over the last 10, 15 years.
Absolutely, yes. The procedures we do now to help, especially with fast heart rates, are usually minimally invasive. We can do a percutaneous, meaning go through your vein or your artery into your heart and find that abnormal piece of heart tissue that's causing this heart rhythm to be too fast or abnormal. And we can use different tools to find those and take care of those, hopefully. We use what's called radiofrequency ablation or cryoablation, either heating or freezing that tissue to destroy it.
I understand that what you're doing when you go in through the veins is you actually, it's like a treatment that slices into the heart muscle itself. What is, by doing that, how does that, the effect of that differ from the use of medicines like Coreg, digoxin, and that kind of stuff?
Right. Those kinds of medications can slow the heart rate through different channels like calcium channels or sodium channels that exist in your heart that cause the normal action of your heart. So we can change that through the medications. With the ablation procedures, what we can do is through heating or freezing, we can actually destroy tissue that causes these abnormal heart rhythms to occur. So it is slightly different mechanisms, but we're changing the ionic compound of the heart and the action potential.
If a person comes into you for a consult, what can you say, or how do you explain to people that it's a lot safer now to start doing cutting and scoring and searing and tearing apart and burning and all this stuff? I'm making it sound gruesome, I know that. But
yeah,
in fact, the progress of heart care and what we've discovered, especially just with the treatment of oral dental hygiene in relationship with that path from here down into the heart.
Absolutely.
It's amazing in the last 10 years what we've discovered.
Absolutely.
But how do you allay the fears of people that come to you for these different types of procedures?
Yeah, we do these procedures all the time. We do them several times a day, hundreds of thousands of times a year, and they're not new procedures. We've been developing these, like you said, for decades now. So in a lot of ways, the medical community has not mastered it by any means, but we've got a good format for completing these procedures and the safest way for the patients to get through these procedures.
I'm sure you've heard this when you went through medical school, that there's a difference between art and science, and the practice of medicine has evolved over the years through a pathway of being an art and another pathway of being a science. But at what point do people like me, older people, when do you sort of make a decision in treating elderly people how far we should go with some of the treatments to slow down heart rates or change if you have mitral valve prolapse, if you have a leaky valve? What makes a person a better than other candidate for advanced heart treatment?
Yeah, it depends on the patient and the situation and how symptomatic they are. The last thing you want to do is harm a patient. Do no harm. That's the first rule. So we want to make sure the patient's healthy enough for the procedure, that the procedure is indicated and it's going to help them in the long run. And that's kind of what we go by. You always look at the benefits versus the risk of a procedure or a medication or anything. So you have to take that person as a whole and look at all aspects.
In your work as in cardiac work, can you sort of draw some parallels between atrial fibrillation and stroke?
Absolutely. Atrial fibrillation is a common, if not the most common cause of stroke in the United States, and millions of people in the United States have atrial fibrillation, and I think stroke remains as the third leading cause of death in the United States. Atrial fibrillation, because it's an abnormal heart rhythm in the top chamber of the heart, can lead to a blood clot in the heart and can dislodge. And once it leaves the heart, the first place it often goes is to the brain, causing a stroke. So the treatment for that would be to give a patient blood thinners and make sure that they don't form these blood clots, or try to keep them out of atrial fibrillation.
Yep. Let's talk about blood thinners just for a second. Coumadin or warfarin, rat poison, is probably one of the most commonly used blood thinners. If you use warfarin, that is a drug that can be withheld and restarted, the dosage diminished, the dosage decreased, and you can do a lot of things if you have to have surgery. But there are some other kinds of thinners that you cannot go off of or onto. So can you explain for our viewing audience some of the causes and effect relationships between the different types of blood thinners?
Right, and as you mentioned, Joe, Coumadin is a medicine, and you look for certain blood levels to remain therapeutic, meaning that the blood is thin enough to prevent clots from occurring. The newer medications, which are called the newer oral anticoagulants or the novel oral anticoagulants, they work differently than warfarin, and their mechanism's different, but also their half-life, their distribution within the body, the pharmacokinetics of these medications, they have different properties, and all of these new medications have different properties amongst themselves, including their mechanisms of action. These medications you have to take according to the FDA guidelines, how often, and they've done several studies on these before they were approved to make sure they were as equal or better than warfarin, which has kind of been the standard for preventing stroke in the past.
How do you see? I believe in doing shows like this and discussing pros and cons of whether or not to use warfarin or some of the new medications, and for our viewing audience to have a better appreciation of what their freedoms are in using each of these medicines. I think we all need to ask more questions, be better informed about our own health, and what some of the things that we should fear or not fear. And I think that honest, open discussions of medicines with doctors that use these medicines on television provide to potential users a source of information they're not going to get. Because how many people watching this show today would know to ask some of the questions that I'm asking you? And I don't particularly like the fact that I've had all these experiences.
Yeah.
But it makes me appreciate more what you as a doctor have to recommend to somebody as a patient. For instance, in my own case, when they monitor my blood and they ask me why my blood, like my level generally stays 2.3 to 2.5. Mm-hmm. I take 5 milligrams of warfarin a day. On my last check, it was 3.2. The first thing the nurse says, "What did you do differently, Joe?" I don't know. The other night at the house, I fixed a spinach omelet for my wife. We had a spinach omelet at supper time.
Sure.
Spinach is something that will cause your blood to thin.
Absolutely.
So we don't appreciate the fact of what our foods, especially fresh foods, what they can do to our medicine. So I think that one of the things has caused people to get into so many medical difficulties is the fact we still simply don't know what to ask.
Right. Absolutely. And we're here to inform you as physicians, guide you, help you. And that's our job. And you as a patient, you're responsible as well for your health care. So it should be a good team approach with the physician and the patient about all of the details of these medications and disease processes. Like you said, whether it's your diet and eating too many green leafy vegetables, lowering your blood thinning levels, you have to be aware of all those kinds of things, what can interact with these medications, and how to take these medications appropriately.
As a doctor, have you ever had a patient say to you, when my heart rate increases and it goes bonkers, it scares the hell out of me?
Oh, sure. Absolutely. Most people, they feel their heart racing. They may get lightheaded, chest discomfort, short of breath, maybe nauseated. And that's a feeling that none of us want to feel. So, yeah, they do get scared with this, and they don't know what's happening. And so that's where a lot of patients come to us at that time.
See, that happened to me. And when I said something about that to my doctor and asked him a question, he came back with the medical manual. It was about that thick. And he handed it to me, and he said, "You study it." And I blew my cork. I said, I ask you a very valid question, doctor. I said, what is happening? I said, I don't understand.
Right.
Well, we had a very frank discussion. That was 26 years ago. He's still my primary care doctor. But I was scared.
Sure.
But I learned, and tell me if my thought process is wrong or not. When I would have these attacks, it was like a panic attack, and my heart would slip, and I get all the symptoms that you feel. And over a course of several years, I finally figured out it wasn't going to kill me.
Right.
Scare me.
Sure.
It caused all kinds of things, but it wasn't killing me. So what was the solution for me? My own personal approach to it was try my very best to control my emotions and not let all this upset me so much.
Mm-hmm.
And I found that if I could figure out a way to relax when I was having these darn things, that was something that helped prevent it in the future.
Absolutely.
And I'm in atrial fibrillation all the time now.
Yeah.
But I don't feel it.
Right.
And is that a good thing or a bad thing or scary?
It's pretty common actually, Joe, especially as we age. We may not feel the common symptoms of atrial fibrillation.
So it's good to get old.
It just depends on each person. Some people feel it. They feel their heart racing. They feel short of breath, fatigue, lightheaded at times. And some people have no idea that they're in it. So this is actually pretty common. Whether it's good or not, I don't know. I think those who don't know can go on like this for years. And like I said earlier, with atrial fibrillation, you can form those blood clots in the heart. And if you're not aware of it and not on the proper medication, that can be dangerous.
That triggers a stroke.
Right.
That's the danger.
Right.
So in order not to promote excessive non-essential use of the emergency room facilities, how does Joe Doe citizen make a determination when to run to the emergency room or not? Or how do you think this? Is there a thought process, Dr. Foreman, that we can go through to?
Yeah, that's a good question. It's a tough question, but I think it's on an individual basis. It's based on your symptoms. If you know what it is, if this is something new, how you're feeling. It's just situational. I think if you have any question that there's something abnormal going on with your heart, then you should probably seek medical care. Now, do we always need to run to the emergency room? Well, you don't know, but what if this is that time that there's something serious going on? So that's a really tough situation.
It's a tough situation. It's a tough question. And the average person does not want to unduly burden a doctor or use the emergency room. But if a person calls me, here's my answer to them. I said, if it's something that you're not really sure about how you're feeling, get yourself to that emergency room and let the professional people evaluate you so you know what is happening.
Absolutely. Like you said earlier, if you're worried about it, then you should probably seek care for it.
Yeah, because that's another good point which you raised, Dr. Foreman. And when we talk about heart care, we haven't mentioned the difference between sexes today, male and female. Why should women be more concerned than they are about heart disease, heart attack, and what are some of the things that are peculiar to women or not peculiar to men?
Yeah. Women and men differ in a lot of symptoms with heart care. Women sometimes are less symptomatic or have different symptoms than your typical symptoms that men may experience with heart attacks or other heart conditions. But women suffer just as much, if not more, from heart disease than men do. So they need to be aware of what's going on and some of the maybe slightly less common symptoms that they may experience.
What are some of the symptoms that women should be more aware of with regard to symptoms of heart attack, Dr. Foreman?
Yeah, well, when you think about maybe a heart attack with the male, you think of the crushing chest pain up into your neck, down your arm, shortness of breath. Left arm.
Left arm.
Women may be less likely to suffer from these common symptoms that we describe. They may have more of a nauseated or abdominal discomfort type feeling. They may not have the crushing chest pain that classically we think of with a heart attack. Fatigue, just anything that may be slightly abnormal for that person as a female may be signs of a heart attack.
My reading is that nausea and fatigue are more common of the indicators for women. They should be getting themselves to the emergency room. And there's so many things that a woman does that can cause nausea and fatigue.
Absolutely.
And it's making an informed, personal, and judgment call is very difficult.
Absolutely, yeah. And everybody should know the risk factors for heart disease, whether it's familial history of heart disease or smoking or diabetes. Be aware of your risk as well as some of the symptoms that may be going on.
Yeah, especially if you've done things that put you in harm's way and you're continuing to do them and you have the symptoms, then you're better advised to get yourself to the emergency room.
Yeah.
The one other area I wanted to talk with you about today, and I know you have a vested interest in it because you work with two of my neighbors.
Mm-hmm.
One put my first pacemaker in, the other one put the replacement in.
Absolutely.
And the wire job the guy did the first time was still good, so I didn't have to change the wires. Yeah. And so I keep pointing over here. Mine's over here. But can you describe for our viewing audience some of the good things and what a pacemaker can do and some of the misconceptions people have about what a pacemaker and defibrillator do?
Sure, yeah. So a pacemaker can pace your heart or make it beat when your normal intrinsic pacemaker starts to fail you. It can make you feel a lot better. Maybe you've been short of breath, you've been fatigued, lightheaded, even passed out. This may be because your heart's going too slow and you're not getting enough blood to your brain. The pacemaker will take over as that replacement when your own pacemaker starts to give out on you. And so we commonly put these in. They go underneath the skin and the leads go into the heart like you described. They're getting smaller all the time. The technology is getting much better. And so it's kind of a common practice now, especially as we age in America. We see more Americans as we age need pacemakers due to kind of scarring down of those normal pacemakers of your heart over time.
And pacemakers, like you say, in size have changed a great deal. I remember, folks, the first pacemaker show I did was with Dr. Johnson, Nancy Johnson. Yeah. And she brought several pacemakers, and one of them was about this big around.
Yeah.
And they put that thing in here, and to adjust it, they stuck a screwdriver onto the skin and into the notch into the pacemaker screw, and they adjusted its darn thing through the skin. You haven't seen one like that.
I've never seen that.
You never seen one like that.
I do believe it.
It's true. That's what they did. But now they can actually adjust this thing over the telephone. That's
right. Yeah. So we actually have home monitors that actually check through the telephone, and then we can make adjustments just by sitting here. If I had the correct machine, I can make the correct adjustments. So we don't need to put a screw into your skin to adjust it anymore.
I know, but I must say this, Lori.
Yes.
The girl that does
She's fantastic. Yes.
Your adjustments there at for you and Dr. Watson, Dr. Johnson. She is one of the loveliest persons.
Absolutely.
And every time she checks my my pacemaker, I keep saying, "How's the battery doing?" It's doing good. And we'll see in 3 months.
Yeah.
And but it seems to be holding pretty good.
Absolutely.
But I can tell you The first time they went in there and they were going to, they got that machine there and they got that little piece of wood or whatever it was. They started thumping this thing.
Yeah.
And I was going up and down. I thought, what are you doing to me?
Absolutely.
And you can feel all this stuff.
Yeah.
And right after I had that pacemaker put in, I had to go to a meeting in Orlando. And a lady that was driving the car, she could see I was getting very anxious. And what was happening was that the vibration of the car was almost in sync with my pacemaker, and it was setting the pacemaker off unduly.
Yeah.
And it was activating that darn thing.
Right.
And she was scared. It wouldn't take me to the hospital. I said, no. I said, it'll be okay. We only have a short period of time. What would be something else that we have not talked about? What would you like to tell our viewing audience, Dr. Foreman?
We talked about atrial fibrillation and stroke. The other thing that we didn't talk about was defibrillators, which are slightly different than pacemakers. Defibrillators are for patients who have had abnormal heart rhythms or have weakened heart muscle, like cardiomyopathy or congestive heart failure. And patients with these conditions may be eligible for defibrillators. Defibrillators actually monitor your heart rhythm and are able to sometimes pace you out of that rhythm or even shock you back into your normal rhythm if this is a potentially lethal rhythm.
And it does it automatically?
Yes, it does it by sensing the same way your pacemaker works for you. It senses through your heart rhythm.
Okay, but a defibrillator is a little bit larger.
Slightly larger, and once again, the technology is much better, and the size of these defibrillators is decreasing. But yes, they're generally just slightly larger than a pacemaker, and that's because of all the complex intrinsic things that it does.
We're out of time. Are you glad you came back to Satellite Beach to work at Wuesthoff Hospital?
Absolutely.
I'm glad you came back too, because you came back to a good doctor.
That's right.
Thank you, doctor.
Thank you. Nice
and I want to thank you for watching today's episode of Helping Seniors.